All right, welcome everybody to our Data Science Zoominar. Today, we're fortunate to have Daniel Larremore and Kate Bubar from University of Colorado. They are going to speak about COVID vaccine prioritization. They just recently got a paper published in Science, I believe, on the topic, and we will be asking questions about that. So just briefly to introduce them, Kate is an applied mathematician and statistician, and is now, if I understand it correctly, a PhD student in the IQ program. And
Yeah, that's correct.
She is now part of Daniel's group, and he's her advisor. And Daniel is an assistant professor at the Department of Computer Science in the Biofrontiers Institute, and his research is developed statistical and inferential methods for analyzing large-scale network data, and he uses these to solve applied problems in diverse domains, including public health, academic labor market. And now we're going to hear a little bit about some of these techniques applied to COVID vaccination prioritization. So thanks again for joining us.
Glad to be here.
Right. So I'll start asking questions right away, unless you want to give a brief introduction. So go ahead.
Sure. I can give just a quick overview of what the goals of our study were and kind of how we approached them.
Great.
The biggest goal of our study was starting last year, trying to look ahead and understand what questions we were going to hope to be able to answer 6 to 9 months from then, which is basically now. And on the horizon, it was clear that this question of who should get the first doses of the vaccine, if our goal is to minimize mortality or minimize years of life lost or minimize infections, that was a question that was going to be on the horizon. And so we took a modeling and simulation based approach. And if I can share screen for just a moment, I'll just give you a very brief overview of kind of the one figure that will show you the gist of how we approach this problem.
Go ahead. We can see it.
So in this figure, we'll just start from the left and work our way over. We considered 5 straightforward prioritization strategies by age. So the first one was immunizing first the children or those under 20. Another strategy would be to immunize working age adults 20 to 49. Another approach might be more simple, just all adults 20 plus. Another approach would be to prioritize the most vulnerable. So these would be adults 60 plus. And then finally, no prioritization at all in the orange, that would be all ages. So these were the 5 strategies that we compared, although of course in working on the paper, we considered many others, but these were the final ones that made their way in. What we then do is use an age-structured SEIR model that included vaccination at various vaccine efficacies, various transmission blocking effects, and so on, and run forward simulations. So in panel B, you can see a simulation where we run things forward without any vaccines, that's the dashed line, and we see infections peak and then subside. And then in the colored curves, you can see what happens if we immunize according to one of these different strategies with a rollout speed of 0.2% of the population per day. And so that rollout period is in this gray shaded window. So as the vaccine is getting rolled out, depending on who gets it first, you see different changes in the total number of infected people over time. Of course, if you have more of a vaccine supply, like in panel C, you're going to get greater effects. If instead of looking at infections, as in panels B and C, we instead think about mortality using age-stratified infection fatality rates in the literature, you can see now in a cumulative mortality scenario, how these different prioritization strategies end up with different numbers of people expected to die from COVID, depending on how you vaccinate. So here you can see that if we vaccinate those people under 20, we really get far more deaths than if we were to vaccinate those people 60 plus. And by comparing panels F and G, you can see that if we just had 10% vaccine supply versus 30% vaccine supply, we would really get different outcomes.
I'm sorry, can I interrupt you real quick? What do you mean by vaccine supply? Is that how many people are getting the vaccine? Or
yeah,
what does that mean?
Yeah, sorry. So here, vaccine supply is in our model measured in what fraction of the population can be vaccinated.
Got it.
So Having enough vaccine for 10% of the population just gives very different outcomes than if you have enough for 30% of the population. And this is really important when considering the COVAX scenarios, where they're expected to have only enough vaccine for 20% of their population if they were buying into the COVAX agreement.
Mm.
So these individual simulations would be far too numerous to really look at lots of different scenarios. So what we do is just look at those endpoints, the cumulative mortality relative to no vaccine, and summarize them in panels D and H over here on the right. So you can see the reduction in infections as a percentage, depending on your strategy, and the reduction in deaths, again, as a percentage, depending on your strategy, where the horizontal axis here now varies that total vaccine supply. So the 10% vaccine supply points line up at 10, and the 30% line up at 30. These black dots in the summary plots are also those points where that prioritized group is now 70% vaccinated, after which we assume that, that the vaccine will just be distributed without any additional prioritization.
Oh, I see.
That sort of reflects the latest information from Gallup polling in the US, suggesting that about 30% of people still would refuse the vaccine if offered one today. And then importantly, instead of just considering one scenario where we're thinking about a particular reproductive number, a particular rollout speed, and so on, we can change that scenario, change the rollout speed. When we do that, if you compare panels D and H with panels E and I, you can see that depending on the scenario, the prioritization curves change in their shape, and they may, in fact, comparing H to I, change in their order, suggesting that you'd get a different prioritization strategy being the best. So this is kind of the walkthrough. We go from the strategies into the models, and then into these sort of model summary curves that allow us to see which strategy would actually be the best.
Great, that's very nice. So can you put that back real quick? So
Oh, yeah.
there was a little inflection point that I don't get why you're seeing that. In the pink line down there, I mean, you see it in also the purple.
Yep.
What is that? Why is that happening?
Sure. So the best way to think about this point is that as we track along the curve up until we hit that dot, what we're doing is prioritizing those vaccines to those adults 60 plus. But we know
so the strategy changes at that point.
Yeah, at that point, we stop vaccinating adults 60 plus and instead just start giving the vaccines out to any takers.
Got it.
When it comes to minimizing infections, like in this panel E, you know, immunizing those folks 60 plus doesn't have a huge impact on infections. And so when we switch strategies from adults 60 plus to just giving the vaccine out to everybody, we get a much better marginal impact, which is why we get this kind of cusp in the curve.
Interesting. Okay, great. So can you explain the current CDC recommendations and if you know, like, how many states are following it? I've seen several examples. I think I have a pretty good idea what the latest is, but if you can share that with our audience, and then tell us whatever you know about what's if you know which states are implementing and which states are ignoring it or changing it.
Yeah, so the first kind of level of the CDC recommendation, what they were calling 1A within their prioritization plan, is focused on healthcare workers and long-term care facilities. And then the next stage, so 1B, is this kind of broader group for frontline essential workers and people who are 75 plus. And
what frontline essential workers, do they define it? That part I don't remember. Do they say who is a frontline worker?
So they give,
oh, go ahead.
I was gonna say, they give some examples of who might be included in this group. They do say that it is up to the states to decide exactly what this means for the specific location. Some occupations that they include are firefighters, police officers, food and agriculture workers, etc. But like we've seen, kind of this category of essential workers can get really messy in who is included in this and who is not, and how much it should vary depending on a given population.
And is the rationale, so if we're gonna now thinking back to your model, to your simulations, those would probably be on the younger side. So the rationale for that, is it that we need them to be healthy to do their job, or is it have to do with the fact that they're exposing more people, or do they not really explain why they have that group up so high?
So the thinking there is, I think, a mixture of different aspects. So it's important to know that in our modeling, we were only focused on infections, deaths, and years of life lost. But of course, policymakers are going to be thinking about other things like, does my workforce, do my police officers, my firefighters feel safe going to work? Are they actually motivated to keep showing up and keep society running? Do the grocery store workers want to keep showing up? Is it safe to reopen the schools, which may have benefits that are just simply untouched by our modeling of mortality? And so, I think that this recommendation from CDC balances more than the questions that we answered.
Yeah, it seemed like that, right? There's a lot of ethics involved, not just public health considerations.
Yeah, but then, as you mentioned before, there are these nuances that CDC kind of leaves open, that the states, in fact, in some cases, have left a little bit open. And I'll give you an example of that. So here in Colorado, in one of the 1B prioritizations per CDC guidelines, we include teachers. And so the state has delegated to the counties. The counties, for instance, here in Boulder, have kind of split responsibilities so that the county and the University of Colorado Boulder, having such a big population here, are sort of dividing efforts so that they can, address their own populations. So here at a university, I'm teaching a course this semester, but I'm teaching entirely remotely. So from the university's point of view, should I be considered a teacher and prioritized in 1B, or should we instead prioritize others? And so, the decision here at the university is instead to say, if you're teaching in person, then you'll be prioritized as a teacher. And if you're teaching remotely, then for all intents and purposes, you're not actually effectively a teacher at higher risk of exposure. But again, that's like so many steps removed from CDC recommendation to the state, to the county, to the university.
Very interesting. So when you first saw the CDC recommendations, you had already been working on this, I imagine, for a while, correct?
Yeah.
So what were your first thoughts when you saw that, and also have you sent these to decision makers, or have you kept it more academic in terms of just like publishing it, which I'm I imagine they have seen it now, but I'm curious about that part of the work.
So the process has been really interesting. So over the summer, the WHO's SAGE group, so this is the Strategic Advisory Group of Experts on Immunization, made a call out to the modeling community, folks who had worked on vaccine prioritization or who had preprints on the topic before, and basically asked, first of all, what are the questions that we at WHO should be asking? And then after collecting all of those questions, they then put them together into sort of a call for modeling, or a call for, not proposals exactly, but a call for answers, and then re-asked those questions to the community. And then they took all of those answers and put them together into recommendations. So the WHO side has been proceeding since last summer.
So you submitted yours?
Yeah, we kind of had an ongoing dialogue with the SAGE modeling group, as did some other modeling groups.
Okay.
So, as I mentioned, while we weren't looking at, for instance, the economic side of things, other groups like the London School of Tropical Medicine and Hygiene have a model where they were looking at the economic benefits of different prioritization strategies. So from the WHO side, this process has been ongoing, and it's been very interesting to have that kind of continued conversation, not just what were the answers, but the part that I found great, they were asking, what are the questions that we should be asking, really drawing on a broad base of expertise. At the same time, in the US, the National Academies of Science, Engineering, and Medicine, we're having symposia, and our co-author on this, Mark Lipsitch, was presenting some of our ideas there.
Interesting.
So I think all of the modeling recommendations, as well as the ethical considerations and the economic considerations, have all kind of woven their way in over the past 6 months into the existing guidelines.
Interesting. So Kate, I saw you shaking your head when I said what you thought when you saw it. Do you have any further thoughts on, like, what was your reaction when you first saw those recommendations come out?
Yeah, so I think it makes a lot of sense, especially 1A, thinking of really prioritizing healthcare workers first. I think everyone I've talked to has been in agreement that this should be the first group to really be prioritized. And then, like Dan said, I think really these recommendations come from combining both the modeling and quantitative work that we have contributed to, and then also these other considerations. And so it is a nice kind of way to bring everything together, because this is obviously a tricky question, and there's lots of different ways that you could approach the problem to think about who should be first in line and kind of what are we most concerned about. Is it kind of these economic points, or is it really protecting people within our community, making sure that the hospitals aren't overwhelmed? Like, there's lots of different perspectives that you can take to think about this question. And so I do think that the CDC recommendations encompass a lot of these different points of view.
Interesting. So I have our first audience question. I'm going to go ahead and ask it. So this comes from Meredith Warshaw. Wouldn't how likely one is to be exposed be important? In particular, those who are in essential jobs who cannot take time off due to the lack of sick time, such as grocery store workers, are likely to be exposing people both because they're more likely to catch it and because they don't take time off. So this increases the chances of people in contact with them. So I didn't hear that in your model you included this. I imagine that this gets included into the more random part of the model, but maybe not. Maybe you have done something like that, including that this kind of a variable in your models.
It's a really good question. So I think there's kind of the simple answer to the question, and then the more complicated. So first, the simple answer is that when we look at the infection fatality rate by age, roughly every additional 6 years doubles your risk of death. So if I have 2 workers and one is 12 years older than the other, that worker who is 12 years older is 4 times as likely to die if they have COVID.
They condition on getting it.
Yeah. So conditioned on having COVID. So now we have to ask, in expectation, how many deaths would there be in one age group versus another? So if they're at the younger age group, the probability that they get exposed and infected is 4 times that of the older person who's working.
That's in your model.
No, this is
you get that from this is data.
Just a simple explanation.
I see. Okay. For the explanation. Okay.
But for me, that's kind of an easy way to think about it. If I have 2 workers, one is 12 years older than the other one, the younger person would need to be at 4 times the risk of exposure relative to the older person for them to be equivalent. If that younger person is only twice as likely to be exposed, then the math would still suggest that we should prioritize the older person for the vaccine, because they're still more likely to die, inclusive of both the risk of death conditional on infection and the probability of infection.
So in the model I'm sorry, go ahead, you weren't finished.
Oh, I was just going to say, so the more complicated answer is that in the model, while we don't have breakdowns by, essential worker, grocery store worker, Lyft driver, and so on, what we do have are these age contact structures within the population. And this is based on older work on influenza modeling done by others, where in social contact surveys, they ask people of various ages, how many others do you come into contact with of age 5 to 10 on a daily basis, 10 to 15, 15 to 20, and so on. And for each of those contacts, do you come into contact with them at work or at school or in other scenarios? And so taking these age structured contact matrices, we do see that the younger folks come into contact more with each other and are much more responsible for the spread of the disease. So those folks, in the 20 to 50 age range. But in spite of that, to Meredith's question, it's not the case that their risk of exposure is so much higher that it overwhelms those infection fatality rates. The infection fatality rates for COVID are so much worse for older adults that really kind of drives all of our results.
Interesting. Yeah. So your model does include that variable in a way, because what you're telling me, if I understood you correctly, is that the different age groups have different probabilities of infecting others. Correct?
Yep.
Okay. And you also take into account which other age groups they're more likely to infect.
That's right.
Okay. Interesting. Yeah. Okay.
And in fact, from the data science side, I think these contact matrices may be really interesting to folks. So I just want to actually show, if it's okay, a picture of one of these, because it just helps to make this so much more concrete. So when we think about an age stratified SEIR model, having these contact matrices is really valuable. So this is a study, the first author was Joel Mossong, and sometimes referred to as the polymod study. But what you're seeing in this heat map is those contact rates from one age group to another age group per day on average. And so for Germany, for instance, you can see along the diagonal in this heat map, people tend to associate with others who are basically their age, maybe plus or minus 5. You can also see parent-child relationships on the off diagonal, maybe some older parent-child relationships over here on the right. But if you contrast Germany with South Africa, you can see that the population structure, the household structure is totally different. First of all, we see that the older ages are just, the demographics are overall different, fewer older age people in South Africa. And second of all, across the bottom here, you can see not only a subdiagonal, but this other subdiagonal where you can see grandparents coming into contact with kids. So you can imagine that a disease spreading in Germany and a disease spreading in South Africa are going to be very different. So to Meredith's question, it's a really good question. We didn't include essential worker status, but for each one of our countries that we modeled, and we did include these country-specific contact matrices that incorporate all this information by age.
So questions about can you keep that one up? Why isn't it not symmetric? Is it because it's self-reported so people don't okay? Is that why it is?
The reason is that the units are, if I'm a person of age I, how many people of age J do I come into contact with each day? So the normalization is, or the units here are such that it's self-reports, and so we don't actually expect it to be symmetric.
I got it.
From the perspective of column or row.
So question, two people have asked the same question after you showed this up. This is not during a pandemic, right? That data just comes from just regular times, yep. Or so yep. that must have changed. Is there any is there any updates to what those matrices look like?
Yeah, there have been a few updates. I could maybe post a few of those links afterward if that's okay.
Excellent, very interesting. So that was data. That was one of my questions, by the way. These are mathematical models where you make certain assumptions. How much of those assumptions are data based? Like, I just want to hear in general. Maybe both of you can comment on it. Like, when you're doing all this, how do you decide what to get from data, what to sort of use either your knowledge or experts' knowledge on what experts' recommendations of what the parameters should be?
So since we started this in the summer, one of the biggest questions that we didn't have any data on was the vaccine properties. So what is the overall efficacy going to look like? Does it block transmission? Does efficacy decrease by age? And so because we didn't have really any preliminary numbers to work with when we started this project, we included all of those as parameters within our model so that we could adjust and see, because we know vaccines were going to come out in a few months, we can kind of think about what the different plausible ranges of these different parameter values might look like. And so we can hopefully prepare and suggest and be ready to have a prioritization strategy ready to go based off of the properties of the vaccine. And so now that we have data and we have information from these clinical trials, we can plug these into the models to update it, to make it more realistic since we have this information. And going forward, we can also continue to update these with the most recent estimates. And as more companies have vaccines be approved, we can incorporate this to see if it changes the results or not.
Okay, cool. Okay, so it looks like you did this in R just from those figures. Is that right? So
Yeah.
what do you have the code? Is the code public? I'm sorry if it's in the paper, I missed that. Is it public? Are you planning maybe on having some kind of interactive tool or package that others can use?
Yes, so the code is public and we already do have a tool available to
maybe we can
these.
put it on link on the chat later.
Yeah, definitely.
Yeah, you can do it.
Yeah, so that's a nice way to be able to see, to change the parameters yourself and to see. We have a bunch of different countries included in our tool at the moment, as well as some of these other parameters, not all of them, but just to see for yourself and kind of build your intuition on how these different aspects change the results.
Oh, very nice. I look forward to seeing that. How much was it? I'm curious about your experience using R for all this. I mean, is that the standard tool now these days, and for SIRS models and other the epidemiological and pandemic type analyses? You think it's become the standard?
I see mostly R. I see mostly R and a bit of Python. I mean, my preference is Python because I like sounds judgy, but I like a proper programming language that I can, kind of break things down into smaller functions and not, I don't know, the R kind of scripting environment is not my favorite. But I'd say, across the lab, we basically use C++, R, and Python. Where if we really want to make it go fast, it's in C.
Sure. Yeah, but this one was, how much of what you wrote here you had to go to C++ or C?
None of this. In fact, in case people are interested, I posted the GitHub as well as the online kind of interactive tool where you can change the parameters and see how the different curves start to get closer or maybe overtake each other.
Interesting. I remember this, now that you say C++, it reminds me, I mean, I don't know how relevant it is to our conversation, but maybe it is that there was one, I don't know, very beginning, there was an epidemiologist, if I remember correctly, from England, that was actually in the press quite a bit. And then someone got a hold or found out that the code that they used to make their predictions of how many people were going to die was all like the C code that with, I don't know, they actually named a number of lines. And one of the criticism was that there was no way of really checking if that worked. So I'm happy to hear that you're putting your code up online, and it's R and Python are much more readable than C++ and C, so that's also good. So do you have any thoughts on this? Like, if I tell you I wrote the simulation in C++ and it has 1,000 lines of code, how much would you trust that? If I don't know, just, I mean, I know it's a very general question, but from your experience, what would you say to that?
I mean, I'll just say that there is a difference between how a mathematician writes code, how a computer science professor writes code, and how somebody with industry software experience writes code. Like, if you've written code in industry, you have principles of how you name variables, you have style guides, you have test-driven development. And these are typically not taught in science programs, although I really think that they should be. One of this is not related to vaccine prioritization, but something that I really care about for people in my group here is that by the time you graduate, that you have some sense of how to give a coherent talk, how to make nice and interpretable figures, and how to write clean code. Because as you just mentioned, oftentimes we read code more than we write it. And so having clean code is just one of those things. We actually have some slides online as a reference for students for how to write clean code. But I will say students are typically better than the professors at this. And so probably the slides should go to the professors, not the students.
Yeah, maybe. Yeah, so good. But I'm happy to hear that you're putting it up online. It's not always the case. I think it makes it, if anything else, it makes it more, people trust it more because there's a chance for others to comment and find errors. Yeah, interesting. So another, well, it's a little bit more of a broad question, but I want to hear what your opinions are. There's the first reaction from someone who's thinking like a statistician about this problem, when you look at the data, and you already mentioned this to a certain degree, is that it seems like the strategy we should follow is just base it on age, right? So can both of you comment a bit on what you think about that, or how do you educate people that maybe that's not the best strategy, or maybe you think it is, but it seems like it's caused some debate in some circles, and I'm wondering what your thoughts are.
I would say, taking a global context is very different than taking a US context. So for example, Indonesia is not starting with the oldest folks first and then moving their way down. They're instead trying to vaccinate those who are more responsible for spreading. And in fact, I'll say that our model doesn't make kind of uniform recommendations that you should always vaccinate the oldest adults first. What we find is that there's a trade-off. So I think of this as a race where the vaccine is trying to get to the susceptible people first, but the virus is also trying to get to the susceptible people first. And it's a race to see who's going to get there before the other one. If you have community control of the virus, and so you've reduced that reproductive number, then that slows down the virus. It's easier for the vaccine to get ahead. If you increase rollout speed, you have more vaccine available, it's easier for the vaccine to get ahead. And so this balance between the rollout speed and the virus's speed really determines whether or not one approach versus another would be good. So what I'll say is, in the US, it appears that we've kind of boxed ourselves into a situation where we have high community spread, and we also have some sort of bumpy and not exactly fast vaccine rollout, which means that the solution in our case really should be to prioritize the vulnerable. Of course, policymakers are going to weigh that with other things, but from our modeling point of view, prioritize the vulnerable. But the
vulnerables to death, not to infection.
Right. Yeah. Vulnerability to death. But I'll just say that if we were living in a different country, imagine yourself to be in New Zealand or Taiwan or Korea, and you have basically no community spread, you have the ability to consider a much wider variety of options, because in the race between the virus and the vaccine, the virus is so slow that the vaccine can do lots of different things, like target herd immunity first instead of vaccinating the most vulnerable. Right? We have different options available if the balance between these two factors is different.
Interesting. So there's a new question from the audience, which I think the answer to this is no, based on what you've shown me, but maybe you're considering it, that they're asking about having the outcome be related to hospitalizations instead of deaths. Because I remember especially at the beginning of the pandemic, we were being told that what we want to do is keep the hospitals free. That was the flatten the curve argument. So what are any ways that your model could be changed? What would it require for you to make that the outcome? Although maybe it's not a concern anymore, given that it really actually in LA I hear it got close. So any thoughts on that? Well, you're going to show us some slides.
No, I was going to paste this in the chat. So we didn't look at hospitalizations or hospital capacity as a particular outcome, but there is an excellent paper from Larremore et al. And the link to that is here. They were using models to ask and answer similar questions, but one of their outcomes that they were looking at was specifically hospitalizations. So I would refer to that work where they've really dug into those details.
Interesting, thanks. Okay, so it's in the chat, everybody. Great. So one of the last things I want to hear about, I don't know how much you have looked into this, but what is it? I'm just very curious, and maybe you can help me answer this question. How is Israel going so fast and compared to other countries? Do you know what strategy they're using that makes it different?
So my understanding is one of the key things they did was really talk to the pharmaceutical companies early on. And so they had a plan for how many doses they were going to have. They were really prepared months ago. And so they were one of the first ones to really start thinking about this. And then just in general for their population, there is high trust in their healthcare system. And it's very well developed. They have a strong infrastructure, a universal health insurance throughout the country. And so kind of all of these different factors come into just being both prepared and then efficient once they actually have the doses in hand.
So what's the efficient part now? Like, what is it? They just do it, they go faster at putting the vaccine in people's arms? Like, what does that mean?
Both a combination of higher supply and faster or shorter delay between when they get the doses and when those doses actually go into people. You know, two other things that I'd point out about Israel is that this is not their first recent experience with a mass vaccination campaign. So for instance, they have considered recent vaccination campaigns against, I think they did one against polio somewhat recently. And so they're, you know, this is not their first time down this path in living memory. Another thing to point out is that Israel is a country, depending on how you count things, of around 9 million people. New York City, you know, 8.5 million people. So just in terms of size, the logistical problem is very different in a country like the US versus a country like Israel.
Interesting. Okay. So Kate, a follow-up question. You said that they were ahead and they talked to pharmaceuticals. Does that mean that they basically bought more? They had more vaccines just to start with? Is that what you mean?
It's not public knowledge right now, like the number of doses they have, but they certainly were one of the first to be having this conversation about how many doses they wanted and how much to pay for them.
Great. All right, great. Well, this has been very interesting and illuminating. I want to give you one last opportunity to talk to our audience about how data scientists can help in this area. And maybe Kate, you can talk. We have a lot of students, postdocs that are listening, and maybe you can tell them a little bit about how you got into this and how if you like it or not, and how can they, if anybody's interested in publishing papers like this, what should they be doing?
Yeah, so I've been interested in mathematical biology in general for a while, and then more specifically infectious diseases for the last couple of years. So it was very timely to start this project and be living through a pandemic. But just advice in general, I guess it was nice to have these brainstorming conversations 6 months ago, like Dan was talking about, thinking about what questions are going to be on people's minds and how can we contribute even when there's so many different modeling groups in this space working on all sorts of different questions related to COVID. I think having just really creative conversations, like brainstorming kind of how can we contribute and what things might be interesting and related, like I'm really interested in relating it back to policy. So where can we kind of find the junction between math and academia and these different policy types of questions can be incredibly helpful to really have those, and then making it more concrete, thinking, okay, so how do we turn this into an actual project? And staying up to date on recent literature so you know of different tools and different approaches that people are using is very helpful.
Which includes the bioarchive and such, right? That's not just published literature.
Yeah.
All right. Any other words, Daniel?
Well, I just really like Kate's comment because it really brings me back to when we started this project, which was a lot of conversations that were really focused on the questions. And I mean, the first question that we really grappled with was like, what are the questions that we think that we should be trying to answer here? I think we spent more time arguing about that and discussing that in the first few weeks than we did thinking about any kind of model or how we would answer the question. And more broadly, it's my view that the very best science and the very best data science are those projects where people spend a lot of time thinking hard about the questions. You know, the like sort of serendipity, like this random thing happened in the lab and what a miracle, now I have a really cool study. That happens so rarely. But the best science is one where people really focus a lot on the questions and then develop from there. But these days, there's so much interesting data out there. I think it's also really tempting to like get a data set and then say, what can I do with the data set?
Yes.
In general, as tempting as that is, I always have to kind of punish myself and go back and say, no, focus on the questions first. And I always find better results that way.
Definitely, question first is a advice I totally agree with. It applies everywhere, not just here. All right, well, thanks again. We really appreciate you taking the time to talk to us, and keep up the good work.
Thanks for having us. If there are
Yeah,
other questions, feel free to email us. I'll drop our emails in the chat.
Great. We'll try to add those links into the YouTube video too. Okay. Bye, everybody. Thanks for joining.